It's my pleasure to introduce today's speaker, Tui Yang. And she comes from us from Johns Hopkins University, which is where she did her doctoral degree in the Department of Health, Behavior, and Society, which is sort of the closest analog to our Department of Behavioral and Social Sciences at Hopkins. And she's now an assistant scientist there. Before that, she got a master's degree from the School of Journalism and Mass Communications in Minnesota, the University of Minnesota, and her BA from Fudan University in Shanghai. I was really excited about Tui's work because it really cuts across a lot of the things we're interested in behavioral and social sciences. One, that it focuses on alcohol and HIV, but also that there's a real focus on the social factors that are relevant in that. So I know that she's doing some work that involves social network theory, some that's more qualitative, some that's kind of more traditional quantitative, and I think her talk today will be a bit all over the map, as we'd like to say literally, because she'll be talking about populations both in China and Maryland that are at high risk for HIV. So,
all right.
Welcome.
Thank you so much for the introduction. Thanks everyone for coming to my talk today. And as Chris described, I'm talking a little bit about my research, my past and ongoing research about alcohol use among populations at great risk of HIV in both China and from Baltimore and Maryland. So just give you an overview for today's talk. I will briefly introduce the Lighthouse study at Clear Point, which is a research center in the Department of Health, Behavior, Society at Johns Hopkins School of Public Health. And I will talk a few examples of my past and ongoing research on alcohol use among populations at great risk of HIV. And finally, I will talk a little bit about future research agenda. So during the past 6 or 7 years, I've been involved in a variety of projects at the Lighthouse study at Clear Point. This is a community-based research center in the Department of Health, Behavior, Society at Hopkins. Our research at Lighthouse primarily focuses on HIV, STI prevention, social network, urban health, and substance use risk reduction among most socioeconomically marginalized populations in both domestic and international settings. So here's several pictures of the Lighthouse. We have their interview room and their conference room for group sessions, and several logos from previous Lighthouse studies. So currently, Lighthouse have 5 faculty members working on a variety of primarily NIH-funded projects. So the goal of our study is to improve health and empower communities, both locally in Baltimore, but also in international settings, primarily in East Asia and East Europe. So my research at Lighthouse draws from a very interdisciplinary perspective and uses both qualitative and quantitative methods to study and intervene social structure and structural determinants of health problems, with a special emphasis on substance use, HIV, and mental health among populations in both domestic and international settings. So my current research primarily focused on first to explore the social and structural determinants of health disparity related to alcohol use and HIV. I'm particularly interested in the social network characteristics associated with HIV and alcohol use. My colleagues and I have been analyzing our longitudinal data among heterosexual African-American women in Baltimore. So one of the research topics we have been looking at is to look at how individual alcohol consumption is affected by the social networks alcohol use over time. Another study, we look at the characteristics of the drinking body, how that associated with individual alcohol dependence. Secondly, I'm very interested in developing culturally appropriate and novel HIV and alcohol risk reduction interventions among populations. Recently, I developed an interest of looking at how mHealth can be utilized as a way to do the data collection and potentially for future intervention development to reduce the risks associated with alcohol use and HIV among different populations. Finally, I've been utilized different advanced statistical technique to evaluate public health interventions. So in today's talk, I will give you a few examples of my past and ongoing research, especially in the area of alcohol use within the population at great risk of HIV. So first, I would like to talk about my doctoral dissertation, which was a social epidemiology study of men who pay for sex in China, especially about their alcohol use. So alcohol use is very widely prevalent in China. A study, 2001 study of more than 20,000 people from 5 provinces in China reported that the prevalence of 1-year drinking rate is about 75% among men and 39% among women, respectively. Also, during the past few decades, we have also shown a very rapidly increase of alcohol dependence in China as well. So research has found that the alcohol use can affect the risk and the consequences of HIV infection at different levels. However, the research looking at the risk factors associated with alcohol use and how that alcohol use related HIV risks has not been widely reported. This kind of research are sort of urgently needed, especially in the current context of HIV epidemic in China. So by 2011, there were estimated 780 people living with HIV in China, and the overall national prevalence is about 0.05%. So this figure shows that the HIV epidemic in China was initially driven by a large amount of infections among plasma donors, which in the color of purple, and increasing infections among injection drug users, which is the color of green. Since 2007, heterosexual transmission has become the major transmission mode of all HIV cases in China, and is still increasingly increased during the past few years. So the uprising of heterosexual transmission in China can due to the flourishing commercial sex industry in China. So commercial sex has been viewed as world's oldest profession. I did a research a couple years ago to look at how female sex workers were portrayed in a newspaper in the early 20th century China. So what I found that in contrast to men who often portray as a victim, women who work as female sex workers always portray as a source of diseases and social instability. So this cartoon came from an advertisement promoting medications treating STD. We can see that this man was dragged by a pair of women to the brothel, and eventually he got STD. So when Communist Party came into power in 1949, sexually transmitted diseases were depicted as a direct threat to the socialism. So improving health care is one of the top national priorities. So commercial sex literally were eradicated through the re-education camps for these women and a criminal penalty for their handlers. Commercial sex has re-emerged as a widespread industry since China started its economic reform in the 1980s. While the majority of commercial sex in China is venue-based, but the hierarchy of commercial sex display a very multi-layered spectrum, ranging from the higher rank of hotel courtesan to the middle rank of massage girls to the lower rank of street workers. So commercial sex still remains illegal in China, and there has been periodically suppressed by the police and the public security departments. So this picture shows arrested female sex workers who are shamed in a public square. So we think this kind of periodical suppression may have pushed HIV underground. Most existing research and interventions targeting to heterosexual transmission in China have only focused on female sex workers. There has been a concern that this kind of efforts can be less successful since the burden of behavior change has been placed only among women who often don't have the power to negotiate sex. So during the past few years, there has been an increasing awareness of another party involved in commercial sex, that is men who pay for sex, especially in the current context of demographic shift happening in China. In a national representative sample, 9% of Chinese men between age 20 to 64 reported they have paid for sex at least once in their lifetime. So here's a report from BBC News about China Fierce Bachelor Future. After more than 3 decades of one-child policy and Chinese traditional male preference culture, there were estimated 8.5 million surplus men born between 1980 to 2000, and were estimated as many as 40 million single men by 2020. So many of these men cannot find female partner for marriage, therefore their demand for commercial sex is expected to expand. In addition, as compared to married men, single men, they have with less social support and low satisfaction and less frequent social sexual activity, and single men are more likely to have risk-taking behavior. So why we need to study men who pay for sex in the context of HIV epidemic? So men who have unprotected sex with female sex workers, they are very likely to acquiring or transmitting HIV. In addition, they are very likely to infect their regular or casual sex partners, given the low condom use in non-commercial sex relationship. So given the current context of HIV epidemic in China, intervening commercial sex industry and understanding the role of men who pay for sex in the HIV epidemic are very important. So between 2007 and 2010, I was a project director for an NIAID-funded study of HIV and related high-risk behaviors among commercial sex male clients in China. This was a collaboration between Hopkins and the Sichuan University Huaxi School of Public Health. So inclusion criteria for this study is men aged 18 years or older who have given money or valuable gifts for sexual intercourse at least once during the past 12 months. In this study, we collect both qualitative and quantitative data, and we also collect blood sample for HIV, HCV, and syphilis tests. So we have 3 study sites in Sichuan province. Sichuan province is located from the drug traffic route from the Golden Triangle in the Southeast Asia from the Golden Triangle to the Southeast Asia and Central Europe. So the injection drug use was the primary mode of HIV transmission in Sichuan. However, the new infection cases have shown an increasing rate of heterosexual transmission. So we believe these 3 study sites sort of represent a typical epidemic ongoing trend in China. As I said, we have conduct both qualitative and quantitative study in this project. We conduct 6 focus group and 41 in-depth interviews, and 600 men who pay for sex completed a quantitative survey and provided blood sample. We used the snowball sampling to recruit those men. Basically, the local Department of Health first identify a group of seeds. Those are the men who self-reported they have paid for sex, and asked them to recruit their friends or someone they know also pay for sex and may be eligible for this study. In each study site, we rented a tea house and a karaoke club as entertainment sites. So as study sites, and those entertainment sites provide a relatively safe and comfortable environment for the participants. Also were easily accessible by public transportation. In each study site, we have a full collaboration from the local Department of Health, Department of Police, and the Public Security Department as well. We also form a community-based advisory board, which provided tremendous help in recruitment and survey design. So just give you some sense about the data from the qualitative stage. So here are some quotes from the participants. A 50-year-old married construction worker said, "Everyone is doing that," which refers to visiting female sex workers. And 23-year-old single unemployment participants said, "My friends will see me a traitor if I don't join them to visit female sex workers." A 45-year married businessman said, "Before visiting xiaojie," which refer to female sex workers, "we always drink together. That's the way how we build better relationship." So those narratives suggest that the commercial sex visit in this sample of men is very related to their social interaction norms, which are very network specific. Actually, the findings from both focus group and in-depth interviews suggest that commercial sex visit in this group has been integrated in their social activity. Basically, start with in the evening with drinking, eating, and playing mahjong, and end up a group visit to commercial sex venues. And drinking before visit female sex workers is one of the major themes come from the qualitative data. So we try to look at whether the quantitative data can sort of confirm which we found during the qualitative stage. So here is some demographic characteristics of 600 men in the quantitative stage. The median age about 38, and the majority of them have Han ethnicity is the majority in China, and the majority of them having local household registration, and 83% have been employed. And about 1/5 of them have education higher than senior high school, and over half of them were married. Here's some other behavior characteristics or biomarkers from this sample. And 77.7% have having snorted heroin during the past 6 months. Just remind you that since we recruit people from the local methadone clinic, that's why the prevalence are a little bit higher as compared to other sample of men who pay for sex. And over 1/5 of them reported always drinking alcohol before visiting female sex workers. The Western blot confirmatory test indicate that HIV prevalence in this sample was 1.7%. The HCV was 8.7%. Again, this is because the reason we recruit injection drug users from methadone clinic. And the syphilis prevalence was 5.2%. Regarding the condom use with female sex workers, the prevalence is about 30.5%. Not surprisingly, the condom use with non-commercial sex partners is much lower, which is 3.5% with regular sex partners and 18.1% with casual sex partners. And it's sort of another finding is sort of confirmed what we found during the qualitative stage is over 2/3 of them reported they usually visit female sex workers with friends rather than by themselves. So we look at the risk factors associated with syphilis infections. After adjusting for a list of social demographic background, in addition to snorted heroin, consistent condom use with female sex workers, always wash genitals after having sex with female sex workers, always drinking alcohol before visiting female sex workers is sort of marginally associated with syphilis infections. So we try to look at what kind of men who are more likely to drink before visiting female sex workers. So we, in the adjusted analysis, we found like men who have higher income with main partner with minor depressed symptoms, not surprisingly drinking daily in the past 3 months, are more likely to drink before visiting female sex workers. Also, very interestingly, men who usually visit female sex workers with friends rather than by themselves were also more likely to drink before visiting female sex workers. So we can see there has been a huge burden of infectious diseases coupled with high-risk sexual and substance use behaviors among men who pay for sex. This is a understudy while bridge can be a critical bridge population that who can facilitate the HIV transmission in China. So we found that alcohol use before visiting female sex workers is quite common, and men who visit female sex workers with other friends were more likely to drink before visit female sex workers. So we need to have a better understanding of the social context of alcohol use and sexual behaviors among this population in order to develop a better interventions. So given the Chinese cultural norms of social drinking and toasting, we think the context of visiting female sex workers with other friends as a group can be a great opportunity for men to assess their own risk and potentially facilitate their behavior change. So we think potentially in the future interventions, peers who train as a health educator should facilitate the dialogues in the context where those risk reduction messages are more relevant and salient. For instance, just right before they visit female sex workers, or in the restaurants or bars where those high-risk men socialize. So after the study, we also still collaborate with our Chinese partners in a variety of other projects, and in addition to mainland China, we also work with CDC in Taiwan to submit a grant to look at the substance use among MSM in Taiwan as well. So there has been a lot of ongoing and potential more opportunities for us to do research in China, mainland China and Taiwan as well. So coming back from China to Baltimore, as I mentioned, the Lighthouse. The goal of Lighthouse research is try to improve the health and empower the local community. We are very focused on our research in Baltimore. This is a community with a high concentration of substance use and HIV. So may I ask how many people have been to Baltimore here? All right. I think you must be to our glorious Inner Harbor, right? It's the face of Baltimore. But I have to say, part of the neighborhood is like this, with so many abandoned houses and facing tremendous social issues related to poverty, crime, violence. So the national surveillance data suggests that the highest HIV infections is among African American men who have sex with men in the United States. And Baltimore ranks the top cities in terms of HIV infection as compared to 20 other metropolitan areas. So this figure shows a huge health disparity in terms of HIV prevalence between African American men who have sex with men as compared to Caucasian MSM. We can see that the surveillance data shows a persistent high prevalence of almost around 50% prevalence of HIV among Black gay men in Baltimore as compared to less than 20% among Caucasian MSM in Baltimore. Again, here is also a huge disparity in terms of unrecognized HIV infection between African American MSM and Caucasian MSM in Baltimore. So it's on average, about 70% of those men living with HIV, Black gay men living with HIV, didn't realize they are having the virus. So this situation is a public health emergency which needs immediate attention. However, the previous research didn't find that individual risk behaviors such as sexual behaviors or substance use behaviors can explain the health disparity. So my research interest actually focused on the social context where the alcohol use and HIV risk take place. So here is several ongoing projects in the Lighthouse, very focused on African American MSM in Baltimore. So I'm working on a 5-year training grant. I'm currently in the first stage of mentor phase. During this stage, I'm conduct a formative study with African American men who have sex with men and their key informants to get a better idea of the social context of alcohol use and HIV risks, and conduct a need assessment of alcohol risk reduction interventions in this population. The second study is a Hopkins funded Faculty Development Award to use a smartphone to collect ecological momentary assessment data of alcohol use and the sexual behaviors among African American MSM in Baltimore. I've been involved in another NIDA-funded intervention grant, which is a social network-based intervention, try to reduce the risk behaviors and also increase the HIV testing and increasing the access to HIV care among African American MSM in Baltimore. Finally, I've been involved in a secondary data analysis grant to look at to use latent class analysis and GIS to look at the patterns of alcohol use and the drug use among African American MSM and how that patterns are associated with spatial distribution and neighborhood effects. So in today's talk, I will briefly introduce a little bit about my two ongoing studies about alcohol use among African American men who have sex with men in Baltimore. So first study is, as I mentioned, is part of my training grant is a formative study of alcohol use among African American men who have sex with men in Baltimore. So the purpose of this study is to explore the social context in which alcohol use and HIV risk behaviors take place among African American MSM. So we conduct 31 in-depth interviews with African American men who have sex with men, recruited primarily from their advertisement in the city paper and mobile apps called Jacked. Is a social network apps for gay men, especially for Black gay men in Baltimore. And we use MaxQDA to organize the code and help me to do the data analysis. So I just started data analysis a couple weeks ago, but I would be happy to share the preliminary findings of the study. So here's some characteristics of the men in my study. So the average age about 36, but we are very happy to see that half of the participants under the age of 30. Sometimes we found it's very difficult to recruit those younger gay men in Baltimore. And the majority of the participants self-reported drink at least 2 or 3 times a week. And we see almost half of the participants reported they have been living with HIV. Even though it's a very small sample size, we didn't do any probability sampling, but the problem in this small sample is very similar to the surveillance data shown in Baltimore. So we got a lot we got the opportunity to ask a lot of questions about the communication with their HIV doctor about the alcohol use, how their alcohol use affect their medication taking, treatment. So it's have a lot of interesting discussion on that aspect. As I said, the majority participants primarily recruit from the city paper and the mobile apps. So here are some of the quotes from the participants. We found a lot of discussion about outcome expectancy, how they think what effect can be coming from drinking alcohol. First is about, sex is much better after drinking. And the second is alcohol has been perceived as a social lubricant, especially for them going to the bars, how to start a conversation, and not being shy and being more chatty and being another me. Some people say become another me after drinking. So also we try to look at how they perceive in terms of alcohol use as a norms in the community, especially as part of a gay culture. It seems like a lot of people mention alcohol, everybody using alcohol. In every gay event, you can see people providing alcohol. It's something must as a passport to go to those community events. And it seems like, and we asked one of the participants living with HIV about, have you talked to your doctor about your alcohol use, since he definitely drinks a lot? He said, no, not at all. Why? Alcohol is legal, it's acceptable. Why I need to say anything about alcohol use as compared to those marijuana or hard drugs? That's illegal, probably, gonna affect my health, but alcohol is commonly everybody doing that. So it's kind of perception of such a highly acceptable behavior in the community. So also previous research also found that there has been a high prevalence of alcohol outlets in the urban low-income African-American community. So we asked question about what's their perception of the number of alcohol outlets in their neighborhood where they live. The couple of participants reported there are so many bars and outlet and liquor store in their neighborhood. Even you couldn't find a fresh vegetable or other products on their block, but there definitely you could find a place to sell liquor and other alcohol. So it's very accessible and basically everywhere. But they also related the number of alcohol outlets in their neighborhood to the violence happening and police harassment in their neighborhood as well. So I'm very excited about this project, since there is so many information from the qualitative research, since it's conversation one after another, sometimes just beyond your imagination what the topic is going to come from. So I'm hoping the findings from this qualitative study can inform the next stage of my training grant project. So finally, I will talk a little bit about the mHealth study I'm doing right now to collect the ecological momentary assessment data about alcohol use and sexual behavior among African-American men who have sex with men in Baltimore. So what is mHealth? mHealth is a relatively new public health domain which use mobile information and communication technology to leverage health outcome. Mobile technology can be used different ways in public health research and intervention, including supporting data collection, surveillance, and or enhancing their access to health information, even sometimes can provide diagnostic services. So the goal of this small pilot study is to assess the feasibility of using smartphone to collect real-time data of alcohol use and sexual behaviors among African-American MSM in Baltimore. Second, to describe the real-time and daily social and physical environment of alcohol use and sex. And finally, I'm hoping to identify some modifiable risk factors, especially beyond the individual level risk factors of alcohol use, then can predict risk sexual behaviors among this population. So I've been working with a highly experienced mentor team from it's a university-wide global mHealth initiative. We implement open source Android-based apps called eMocha on each smartphone. eMocha is developed by a team of faculty members in the School of Medicine at Hopkins. So eMocha has been utilized in different projects almost around the world. So that's where eMocha has been implemented. So it has been developed for a while. So it's a very good apps for further data collection. So my study will recruit 20 participants and ask them to carry a smartphone which have been installed by their eMocha, and ask them to carry the smartphone to up to 30 days. So I'm going to collect 3 types of data on a daily basis. The first is events contingent data, which participants will be instructed to initiate their entry after one episode drinking. So So in the event questionnaire, they will be asked, where are you, who you drink with. Also, I'm asked questions about alcohol expectancy before they're related to that specific episode of drinking. So second type of data is a daily questionnaire, which participants will be asked questions about what have happened during the past 24 hours, including their alcohol use, their sex events, and also in addition to alcohol use, I ask questions about whether they use other illicit drugs or cigarettes. And also for people who have been put on HIV medication, I ask questions about their medication adherence during the past 24 hours. Finally, each participant will receive 3 random prompts between 10 a.m. to 10 p.m. So the random prompts will basically ask their immediate mood, their surroundings, who they are with, where they are doing, and also their potential environmental cues which can trigger their alcohol use. For instance, have you seen any alcohol? Have anybody offer you a drink during the past hour or so? So those kind of questions. So for this EMA data collection, we are very sensitive to the participant burden, since we don't want people being burned out, especially as a relatively highly demand data collection. So we expect each participant will spend less than 20 minutes to finish this question on a daily basis. And we are just piloting the data collection among 3 participants. And before the full implementation, we get their feedback and see whether any modifications are necessary. Besides the EMA, each smartphone had a GPS system on their phone, so we were able to collect some GIS data which potentially provide some information for future structural level intervention. So the majority of the social and behavior study of substance use has relied on the reliability and the accuracy of retrospective self-report of sometimes very highly sensitive information. Mobile technology allows participants to record their daily activities on an electronic device, in this case a smartphone, in their real natural environment. We think the information from the EMA is less biased as compared to survey data, which more likely is subject to social disability and memory lapse. And also in the field of substance use has been some hypothetical objection of this kind of data collection, since people think, oh, substance users, they are not willing to, or not capable of complying such a highly demanded protocol. However, the previous studies among different populations, including some studies at Hopkins, found a high compliance of from the participants, including crack cocaine users in the treatment. MSM, not only in the United States, but also in other cultural settings, they are not disproportionately affected by HIV. They are also less likely to participate in HIV prevention program, to have HIV testing or access to care. We need to address the issue about distrust, fear, and confidentiality. Given the high ownership of mobile technologies among MSM worldwide, I think mHealth is a great place for future data collection and potentially intervention development among this population worldwide. So I'm hoping the data from this EMA project and my formative study can come up nicely and generate preliminary data for future research. So mHealth is a rapidly developing area, and the mobile technologies network are more accessible and affordable around the world. We think that the impact of mHealth on public health research can be significant. However, after more than a decade of the introduce of the mHealth, those expectations are far from being met. So here is an article from New York Times. The title is "Benefits of Mobile Health on Hold." So I very like to share the quotes with you guys. It's an mHealth project is as complicated as any other health project, just with a phone attached. So most of the time we know there is a delivery system there, but we don't know what to deliver, whether people are going to use that in a sustainable way. So I think that we're all excited by this shiny new product, but I think that the real impact should come from the thinking of the cultural and professional context where the mHealth projects and programs are implemented, mHealth project or interventions should make things easier rather than adding complexity to the difficult and challenging lives a lot of participants may have experienced. So I think a culturally appropriate and sustainable mHealth intervention need to involve participants at every stage in order to create out more sustainable and scalable interventions for a variety of populations. As far as for the future research agenda, I think the rapid rate of adoption of mobile technologies in public health research and interventions also requires a careful consideration of ethics issues related to the use of mobile technology in our research. So my colleagues at Hopkins recently published a paper about ethical issues in mHealth research involving person living with HIV/AIDS and substance abuse. I think I encourage everyone who is interested in this area to read this article. I think one of the suggestions from this article is about the existing standard and the best practice of ethical issue may need to be supplemented with additional guidelines, especially in the context of mHealth, in order to make sure the vulnerable populations can be fully protected. So I think that in the research field and also in program implementation field, we need to have more discussion of ethical issues related to mHealth. So finally, I would like to thank my colleagues and mentors in a variety of institutes, including people from School of Public Health, School of Medicine at Hopkins, and also my mentor from Emory, University of Connecticut, and UNC in Minnesota. And thanks for NIAAA and Hopkins CFAR for the funding, and my colleagues from Lighthouse and my Chinese collaborators. Without them, there is no way we can do any research in China. And a lot of my friends have their valuable inputs on my research. And last and not least, all the participants in my study. I think just, I think that they just sit there and share their most intimate and sometimes very sensitive information about their life with a total stranger. One of their African-American MSM, once we finished the interview, he said, "Oh, you are the first Asian woman I have talked to, except the women working in the Chinese takeout." He's very enjoying the conversation with me. I'm just feel so honored to be part of the process, and they are just amazing. They just remind me about the human being resilience and remind me why I come to the field. All right, thank you. Happy to answer any questions. Yes?
Just in the context of China, I was curious whether you know or what your sense is of how much the men who are married, how often their partners would have known, or their spouses would have known their use of sex weapons.
Yeah, I think it's first. I think it's a very close network in terms of they have a group of men who pay for sex together. They sort of have agreements, don't spread out the word outside of the network. Sometimes, for instance, one participant said, if I don't join them, I'm a traitor, since they have the suspicion from their friends, if you don't join me, you're going to tell our wives about what we're going to do. So has been, we didn't ask exactly how much, what kind of knowledge their wives know about it, but it seems like they know in their network has been very acceptable behavior, but outside in a larger community, especially in a larger context of the society, painful sex is still something very stigmatized. So they try to keep everything, stay in the room, these kind of things. Yeah.
I was just taken by how strong the commonality was among the men, and obviously they're recruited for that purpose. That, it seemed like as they were talking about it, that it was so normative. So I was wondering if that's simply because of the communities they're in, as opposed to the
that
sounds like it really is.
Yeah, I think the norm you need to take into consideration which network we are talking about. So within their commercial sex visit group, they definitely common acceptable behavior. But if you talk about the larger community, it's another issue. So, yes.
Does that then become their
Mm-hmm.
then turned off and not used?
Mm-hmm.
How long do they get to keep it?
Yeah, I think that's a good question. Actually, we have our one grant. At the baseline, we ask about the ownership of smartphone. Actually, even though a lot of those men who don't have a job, who don't have a stable income, like 30% of them own a smartphone during the past 6 months. So for my study, I will give them a smartphone to carry up to 30 days. So I also give them incentive in order to keep their phone and give me back. So and also the plan I got in addition to unlimited data plan, which need for them to fill their EMA data collection, there have been 400 minutes for them to use. One of the reasons I purchased the phone plan also is for us to track them, to remind me, since I didn't mention each participant is going to come back to the center after 1 week after the study of the data collection. One thing is we're gonna do a CASI in terms of what they did during the past 1 week in order to see how their data correspond to their EMA data. Another one is about their sort of satisfaction about what's their feedback about using their phone to do their data report. So basically, yeah, I think they're gonna use that up to 30 days, and we give them incentive to return the phone. But they have the chance to, in case they lost the phone, we're gonna give them a second phone. But the protocol is if we lost the second phone, you are disqualified from the study. Yeah. So basically, it's a high ownership of a smartphone in this population. It's something, even though they don't have internet at home, but it's sort of smartphone is pretty much very trendy among this population. Yes.
So given that many other cities maybe they might be comparable have certain districts, like the Castro district, for example, MSM communities in Baltimore, when you were tracking them, what was the impact of knowing where they're going?
Mm-hmm.
You had a slide about the lines moving around.
Mm-hmm.
What was that used to?
So you are asking about what's the utilization of the GIS data, right? I think it's a good question. I think can be used different ways. First, I based on their report of their high-risk behaviors, especially their drinking can lead to high-risk sexual behaviors. We can identify, based on the report where they're drinking, we can know the hotspot of most risk bars or venues where they are drinking, and potentially those venues can be a place for future intervention. And I didn't mention, I also collect data about their experience of violence during the past 24 hours. So that's something I'm also interested in, to see where exactly in Baltimore those black MSM experience violence and how that can lead to potential intervention. It's surrounding with the bars or other places, the potentially can identify those risk geographic locations for future potentially interventions. Yeah.
To be able to take certain events and say on any day or time in which a certain thing is reported,
Mm-hmm.
and then be able to map
Yeah.
where those happen across all subjects.
Yeah, absolutely. Mm-hmm. Yeah, that's right. Yes?
Excellent presentation. Thank
Thanks.
you so much. I also had a question about the mobile health piece. So one of the critiques about mobile health is whether or not the person that is filling out the survey is actually the person and it's not a friend or someone else. What mechanisms do you have in place to ensure that it is the person that's actually the participant that is
Mm-hmm.
actually filling out the survey?
Each participant is going to be assigned with their unique password, and of course in their consent form we want to make sure they keep their phone and keep their password only to themselves. So that's the things we have a good faith in terms of not others fill the questionnaire for them. So it's not we can 100% complete control the situation, but I think in the consent form, and each participant is going to receive a training, like half an hour training before they can carry the phone for the study. So the training including the protocol, how to, I assume how to use the smartphone can be easy for them since a lot of them using that. But in terms of how to answer the question, how to make sure you don't lose the phone, how to enter the password, etc., going to be a necessary training for them before they go into the field. Yes?
I was curious about the GPS and tracking data and linking it to individual labs for alcohol hotspots and co-workers. Could you talk a little bit more about the potential ethical implications when you as a researcher
Mm-hmm.
you're required to report?
Mm-hmm.
Given that you know a potential institution as a hotbed for crime and violent activity,
Mm-hmm.
what are some of the implications of that?
I think it's a good question. I think one of the criteria for ethical study is scientific validity. I think we have a good scientific validity to do this kind of research, since potentially I think interventions beyond individual level is almost always more powerful and sustainable. I think that's the point for us to look at the factors beyond the individual level, and the structural level is sometimes is very powerful, but sometimes we don't have the good data, and even don't have we have a good data but don't know how to analyze that. So I think in terms of reporting, I think it's just I think it's common behavior in the scientific community is like we don't report those identifier information in a peer review manuscript. I think that's a common sense to do that. So I don't think we are necessary to point out those venues, bars, and associate that with some negative aspect. Report to a particular agency? I don't think we have the responsibility to report to the police, I think.
But if you have a certificate of confidentiality,
Yeah,
then
yeah,
you
that's right. I think all our study at Lighthouse, we apply for a certificate of confidentiality. We are subpoena from the court to release any illegal behaviors. Yes.
What is the participant feedback regarding the GIS tracking? Are they okay with that? What is there?
Mm-hmm.
Is there any pushback, or are they aware that they're actually being tracked?
Oh, absolutely. In the consent form, we tell them everything. That's our basic responsibility for us to tell them fully. They will be fully informed what kind of data we're going to use, how we're going to use it, what kind of information we're going to report in the future, potentially manuscripts. That's a good question. I think just since we just started piloting, we haven't got the feedback from the participants yet. But my mentor, he did a research a couple years ago to do almost exactly the same kind of data collection among injection drug users in Baltimore about their drug use and drug craving, and it seems like they are doing fine with doing the pilot study. Even right now, they are doing intervention, use a smartphone as a peer navigator to make sure those injection drug users retention in HIV care. So they also collect some GIS data. I think that doing research with vulnerable population is a process of gaining trust to each other. I think we are not in the position to report them to any authority. I think it's just the purpose of want to make sure they understand we are in the position of getting feedback, get help from them, and let their voice to be heard, and get good data in order to help the community as a whole. So I think that's the basic trust we need for each other.
Did you get any kind of a sense of your response level in using this mHealth technology? If they were more inclined to respond because it was more convenient for them to have this device, and also if the information you felt like was more honest because they were not face to face with the person, so their comfort level of saying what was going on at any given time.
Yeah.
Kind of a higher rate with this material information you're looking for.
Yeah, I think that's a good question. I think that's one of the research aims for my studies, to the feasibility of collecting more reliable and reliable information, especially about their alcohol use and risk sexual behavior. So we have the baseline data collection filled by Cassie, and we have 1 week data collection after they come back to the center, we also had a fourth week data collection. They come back to the center. So we have multiple data collection, like a regular data collection once they come to the center, fill out the survey. So we're going to compare that to the EMA data to see how that what's the corresponding rate to see whether they are which one is more reliable. I think one of the purpose for the random prompts is just randomly sending them the questionnaire, ask them to fill out the question. One of the questions about did you drink during the past an hour, even though they may not initiate their event contingent survey, but the random prompts probably could catch up some of their underreporting alcohol use. So yeah, I think that's a good question. I think I'm just looking forward to see the data set and see. And I don't know anybody have done, probably previous study have using collect EMA data among this population, but I think the smartphone definitely is very user-friendly. We're going to give them not the latest one, but the previous generation of Samsung Galaxy phone is a very big screen and user-friendly, and the question have been a big font, you know, just a very user-friendly. I'm hoping just reduce the participant burden is one of the goals for this study as well. Yes. All right.
Thank you.
Thank you so much.